Hi, I'm Dr. Ben Quist, and I've got a special episode of the Form of Fitness channel for you today. I have the pleasure of interviewing local cardiologist Josh Lieberman about the one test that you probably should have done. Many doctors sometimes don't recommend this test, so find out what that test is and why it's important next. Stay tuned. I'm here with Dr. Josh Lieberman, a good doctor. So thank you for talking with us today.
Thanks for the invitation.
You're welcome. It's our second video together. This is pretty exciting.
Make it a habit.
Yes. So if you could just explain to our viewers, what are heart scans? What are they? When did they get developed? Just some basic broad information about them.
Right. So, there's a lot of different names for the test that you're talking about. Some people call it a heart scan. Some people call it a calcium score. It's known by different things. Calcium score is basically a very fancy x-ray of the heart. It's a low radiation CAT scan of the heart. Doesn't involve any injections or any IV dye that goes into you. I tell patients to think of it just as like a mammogram for the heart. The technology for doing these has actually been around since the 1980s. It started as something called electron beam CT scans. And then with the advent of kind of the modern CAT scan machines, what we call multi-detector CAT scans, you can basically do it on any CAT scan machine there is out there. So we've been doing these kinds of tests since the mid 90s and certainly the early 2000s. And in the beginning, it was, it was a little bit more expensive. And now it's, the price has come down in most areas quite a bit. And it is probably one of the most powerful things we can do to assess somebody's risk of a future heart attack or cardiovascular event.
So, and this is something that I'd really like to get to as far as it's wonderful to have a cardiologist question on this. So when you look at the realm of, even I was listening to a podcast today and there was someone talking about we need to assess your risk of heart disease by looking at your LDL versus your HDL and your total cholesterol. And that was the answer to how to know whether you had a problem or not. When you look at things like blood tests, which are kind of the common thing you get at the doctor's office, every annual physical, you're going to get a battery of different tests versus a heart scan, which is the more predictive indicator? Or I guess what is the more powerful tool to assess a person's risk of actually having a cardiac event?
Yeah. So without question, research study after research study over the last 20 plus years has shown that there's no more powerful predictor than a calcium score, than a heart scan. When you compare it to any other test that we've kind of thought about or conceived of to do non-invasive evaluation of whether someone could or could not have heart disease, calcium score beats all of them. Whether it's risk calculators that add up, demographic data like your age and your sex and your family history and blood test values like LDLs and HDLs and CRPs. So we call those risk calculators, and there's various different ones out there. Whether you look at what's called a test called an ankle brachial index, which looks at blood pressure in the arm versus the leg to see if you might have blockages in the leg. Whether you look at ultrasound of the carotid artery. When you compare a calcium score to any test, calcium score wins every time in terms of its predictive capability. And part of the reason it does that is because all of these other tests are themselves looking at surrogates or predictors of whether or not you have disease. Your LDL level tells you a lot of information. And we know the higher your cholesterol, the LDL level, the more likely it is that you have risk. But it's not a one-to-one relationship. And there's certainly people out there that have high LDL levels and they don't have heart disease. And there's people we know that have lower LDL levels and they do have heart disease. So it's a surrogate and it has good correlation. But with a calcium score, we're not depending on a surrogate. We are actually looking and seeing that you actually have disease. It's not a predictor. It's not a surrogate. It's not something that suggests you might in the future. We are seeing whether you actually have disease now. And there's no more powerful tool than knowing that you already have disease or you don't.
Wow, that was well said. So I hear this a lot too, just from in my realm of personal training customers or physical therapy patients. People will say things like, well, because after hearing about heart scans from you, I've been kind of recommending or just making mention of them to people, that they, that might be a marker to possibly look at. But I hear a lot of, well, my blood work was great. So, my cholesterol was fine. My blood pressure is good, things of that nature. So I don't need a heart scan, so I guess and you kind of answered it already, but just kind of hammer that point home.
Yeah. So heart disease is the number one killer in this country, and it has been for over 100 years. And we've been checking cholesterol levels and blood pressure. We've been talking to people about lifestyle. We've been talking to people about diabetes control. And despite getting people to goal cholesterol, and goal blood pressure and goal sugars and all these things, heart disease remains the number one killer. So I would argue we got to do something different. There are plenty of people out there that I've come across in 20 plus years of doing this, that have normal cholesterol and still have a heart attack. And it's not just my experience. The research shows, the American Heart Association supports research called Get With the Guidelines. And we know from years of Get With the Guidelines research that about 50% of people who come into the hospital with a heart attack had normal cholesterol at the time of their heart attack. Now, I'm not saying that cholesterol is not important, but it's not the end all be all. You can have normal cholesterol and very high levels of inflammation. You can have normal cholesterol and very high levels of sugar, and you can still be at risk of a heart attack. So definitively, having normal blood tests is not a get out of jail free card where you don't have to worry about heart disease. And just one more comment, I would say we need to do something different. We need to break the paradigm, because the current paradigm has persisted for decades, and yet heart disease is still the number one killer. And we know that 50% of people are diagnosed with heart disease at the time of their first heart attack. So half the people out there, we learn that they have heart disease when they have a heart attack. So obviously we're missing the boat. And these are not all people that don't have doctors or don't see, that aren't taking care of themselves or are living under a bridge or something. These are people who are living their lives, who think that they're doing the right things. And the first inkling we know that they have heart disease is that they come in with a heart attack. And the real problem is that about 1 out of 8 people die with their first heart attack. So for a lot of people out there, the first inkling that we have that they have heart disease is already too late. So we need to do something different. And calcium scores are a very powerful tool at identifying who is at risk, but also very importantly, who is not at risk. Because if you have a 0 score, and we can talk about it in a second, I'm sure, about what the scores mean. But if you have a 0 score, meaning you have no hardening of the arteries whatsoever, that puts you at a very low 10-year risk of event, which means that you have time to work on lifestyle, diet, exercise, all those things, and you don't need to go on treatment.
Well, that was a very scary segment. As far as the first symptom that some people have is the fatal heart attack, and that's why I wanted to make this video with you and talk about this a little bit, because the downside of not getting it right is just pretty big, right?
It could be tragic.
Yeah, tragic, catastrophic downside, So I have a couple questions that I think would be helpful for viewers in general. In your opinion, what is the trigger for getting a heart scan? Is there a certain age? Is it being a certain gender? Is it a certain risk profile? Or is it, when is that, when would you recommend those people seek out that?
So the test is looking for calcified plaque. So all plaque starts as a soft, waxy substance that for some of us even starts in our teens and 20s, but it takes decades to harden and solidify. So it makes no sense to get a calcium score looking for calcified plaque in your 20s. It starts, maybe it makes a little bit of sense in your 30s. We know that there are going to be some 30-year-olds with calcified plaque, but it's still a very, very small percentage of the overall population of people. But as we get older, there is more and more of a chance that plaque has been there long enough to calcify, and we would see it on a calcium score. So certainly, I think it's reasonable for everybody at age 50 to get one of these. If you have significant risk factors like a bad family history, I think thinking about it at age 40 or 45 is very reasonable. If you have an awful family history where everybody in your family had a heart attack in their 40s, starting 10 years earlier in your 30s to get one of these, I think is very reasonable as well. It's going to be a rare person that needs to get a calcium score in their 30s. It's a little bit more common to need, a little bit larger population that would benefit in their 40s, and basically the entire population probably would benefit in their 50s, I would say.
Interesting. I've kind of wondered about that, so family history is kind of maybe one of the bigger.
Family history, it's again, because we can't quantify it. We can't say, oh, you have 90% family history or 90% there's no way to quantify it really. And so if somebody has a bad family history, or again, if you're 40 years old and you don't have a bad family history, but your cholesterol is running high and your doctor wants to put you on a medicine, I think this is a very reasonable test to obtain. And if it's 0, again, we have very, very good evidence that medicine, certainly over the next 5 and even out to 10 years, is not going to improve your outcome in that time. It may improve your lifetime risk, but there's no harm in if you have a 0 score and wait till you're 45 and getting another test, or age 50 and getting another test, and waiting to start medicine if that score turns positive.
Just piggybacking on the question of when to get your first one. If you get your first one and it's 0, what would be the time frame? Is it 5 years, 10 years? I've heard different.
Yeah, I typically recommend 5 years unless there's mitigating factors like somebody's a pack-a-day smoker, somebody has poorly controlled diabetes. Well, the conversion rate from a 0 score to an abnormal score is a lot more rapid in those patient groups. And so it's not, again, the 0 score is not a get out of jail free card for the rest of your life. But if you're living pretty clean and your risk factors are not awful or poorly controlled and you have a 0 score, I think 5 years or 10 years is a very reasonable time frame.
On the converse, if you had a bad score, like me, do you ever even get it done again?
Not necessarily. It just depends. There's certainly an argument can be made to repeat a scan in 5 years, 3 years, 4 years, sometime, and to try to see if we are slowing down the curve of acceleration. And that's where I really pay attention to somebody's percentile rank. So where your score ranks in comparison to your peers.
Sure.
For example, if you get a score and it puts you in the 90th percentile, and we put you on aggressive preventive therapy, and we scan you again in 4 years, and you're still in the 90th percentile, then we're not doing something right? Because you're just keeping track with your peers. You're still higher than 90%. So there's something that we're missing. And I would use that data point to say, okay, Ben, what can we do better? What do we need to do better? Do we need to drive your cholesterol down lower? Do we need to fix your shirt? We need to do something better. On the other hand, if we put you on aggressive therapy and you go from the 90th percentile and 5 years later and you're in the 80th or the 75th, well, now I think we know we have evidence, again, I would say, that we're doing the right thing, that we're on the right track. And over time, you're going to keep falling off that curve where you're in the 75th and then the 65th and then the 55th. And then by the time you're 90, if we're silly enough to want to get one of these scans again, maybe now you're in the 10th percentile rather than the 9th.
So I appreciate all the good work you're doing with the clients, the customers that I send over here, and appreciate the time that you spent with me today. And I hope that, this information helps other people understand how important this test might be for them.
Great.
All right. Awesome. Thank you.
Good to see you.
Good to see you.